right, so now we're going to talk about what y'all just saw. So this was Karen Xiao's presentation. She is sick, so we're giving it in her stead. The case is you have a 23-year-old male with a history of right shoulder dislocations twice in the past, coming in for right shoulder pain. Was at a baseball game, reached up to catch a fly ball, and the shoulder started having pain after that. He has an obvious deformity and a squared off appearance on his exam. Clinically, you know that this patient has a dislocation based on your exam. In general, a lot of times we want some imaging confirmation. It's a super busy day in CCT, x-rays backed up, transporters aren't coming. You've been waiting for a portable x-ray for your tube confirmation for 30 minutes. Well, spoiler alert. An alternative to your x-ray is ultrasound. So this is a non-traumatic shoulder dislocation, and so you can use ultrasound as your sole imaging modality. If it was related to a fall down the stairs, then you need to get x-rays to make sure that there's no other fractures that you're going to be pulling on this arm during the reduction. But for a non-traumatic shoulder dislocation, you can use ultrasound. And so the anatomy that you're looking at here, you use a curvilinear probe on the posterior part of the shoulder, and you see this is the humeral head here. This is the glenohumeral fossa, and this is a normal alignment with the scapula here. So you're looking for these things to be generally in line. And this is what it looks like when there's a dislocation. So again, your probe is on the posterior part of the shoulder. So this is posterior and this is anterior. So in this case, your your humerus head is all the way down here. And this is that glenohumeral joint. So this is an anteriorly displaced humeral head. And this is enough to have your diagnosis. These can also be used in real time for confirmation of your reduction, which is really helpful. Instead of being like, oh, did I feel a pop? Maybe it's in, I think it's in, we're not 100%. You can just check instead of sending that patient to x-ray, having them come back and it's still out, because that's going to be a delay of care. The term blocks we're going to be talking about today are the interscalene and the superior trunk. Sorry, you're just over there. Interscalene and superior trunk nerve blocks. These are very, very similar. They're done very close to one another. They're basically just two different options, two different areas, and they get the same anesthesia. So indications for this are going to be a humeral head or shaft fracture, especially for those elderly patients. You don't want to procedurally sedate. They have a severely deformed humeral head, a humeral shaft. That they're going to need, like ortho is going to be yanking on it. It's a good option for that. Shoulder dislocations and deltoid abscess. Contraindications are any overlying skin infection. And then the main thing that you have to think about with the interscalene block is that patients with poor respiratory reserve may not be great candidates. And that's because when you are blocking the brachial plexus, there is a good chance that you're going to have involvement of the phrenic nerve, which will cause paralysis of half of your diaphragm. In a normal healthy patient like JFK, that's not going to be an issue. But your patients who've had a lobectomy, have severe COPD, just in general have very poor respiratory reserve, this is probably not a great option for them. And I will make the caveat of if you're considering procedural sedation for that kind of patient, like for any patient, the respiratory side effects and risks of a procedural sedation on studies is higher than the potential respiratory effects of a block. So just something to consider if you're making the decision between a nerve block and procedural sedation. And then because of the possible paralysis of half of the diaphragm, you cannot do bilateral blocks because then they have no diaphragm if that were to happen, and that would be bad.
But you can intubate them.
Yeah, but then you can intubate them and get another procedure. So the difference between these two blocks is really just where along the brachial plexus you're doing it. And so for the interscalene, it's the C5, C6, and C7 is that stoplight that you see in between the two muscles. And then when you go to the superior trunk block, you're standing just a little bit caudally, and you're going to have where the C5 and C6 nerve roots have come together. So you're just getting that superior and middle trunks. It's a little bit less clearly delineated on the ultrasound. It just looks like a little bit more of a nebulous blob of nerves, whereas the interscalene has the clear 1, 2, 3. So for the interscalene block specifically, this is the coverage that you get. They do, this is a very common anesthesia to be done for shoulder surgeries. So they do entire shoulder surgeries like arthroscopic and things.
This really exactly this. I can feel my pinky. I can feel part of this finger right now. All this is completely right now, this is just pins and needles down here.
Yeah.
Otherwise, yeah. So it's pretty impressive.
Awesome. Yeah. So for the probe, you're going to be using the linear transducer. You're going to be doing the approach from the posterior side of the neck, like was shown. The most challenging part of the setup is just you have to think about it, whether they're like sitting up against the back of the bed or lying on a table like that. They really have to be able to turn their head because you might not have room for your needle and your syringe, like from the posterior neck, like the bed might get in your way. So just make sure that you're preparing for that and setting that up ahead of time. For the interscalene block, you can use a spinal needle or you can use a normal like cutting needle. For JFK, we just use like a 23 gauge. The models are all using the spinal needles. The benefit of that is that they're a little bit blunter tipped. And so if you were to hit the nerve, it's a little bit less chance of damage. But the cutting needles are seen a little bit better on ultrasound. That's pretty much it approach wise. Oh, and it's going to be like 10 to 15 mLs of volume that you're injecting. And so you're always going to have to figure out your weight-based dosing. For this block, because it's a procedural block and because you have the potential side effect on the diaphragm, you want to be using lidocaine, not bupivacaine. You don't want a longer acting anesthetic in this case because you just need to get the procedure done and move on. So figure out your weight-based dosing for lidocaine. It's most likely, unless the person is very small, going to be at least 10 to 15 mLs. And then you can put that entire volume into the block. I only did 5 cc's on you and it's already, so that's pretty cool. So this is the target that we're looking at that we were reviewing earlier. You have this SCM that comes over on the anterior side, and then your anterior scalene and your middle scalene. These are the 1, 2, 3 blocks. When you come in with your needle, you're trying to come in kind of on this superior side. And then you could see once I was injecting anesthetic, it kind of opened up this area and gave you more space to move your needle throughout that area. The goal is to bathe around the nerves. You are not trying to, do not stick the needle into the nerve itself. At the nerve roots, they're very big. They're hypoechoic. They're pretty obvious. And so that's the goal there. And I don't really like that picture. Any questions about interscalene and what we talked about so far? Yeah.
Is it a motor block as well?
No.
Yeah. That's something for everyone
Can you
else to know that like some blocks are motor as well. So just keep that in mind. Like if you do blocks and blocks, is it going to take out the
And that's classically talked about with, yeah. It's classically talked about with like fascia iliaca of why some people like pang versus fascia iliaca, but even with fascia iliaca, you really end up usually not getting that much motor. But yeah.
You also probably have that. Like,
yeah, sure. That's true.
If you're calling orthopedics, they will probably want to get a full neurologic neurovascular exam beforehand. Try to get them, if it's for like a humeral head depth or something, try to get them down there before you do this.
Right? Yeah, absolutely.
Cool. So superior trunk block, pretty much the same thing. You're just going lower. And honestly, the visualization on the ultrasound is a little less clear than your 3 stoplight sign. What you're going to be seeing is these beef, chunky honeycomb areas as these nerves come together into like one trunk. So it's the same distribution. This picture with the ultrasound probe. So if you can imagine, Jamie's interscalene is just above, and as you slide down the brachial plexus, you'll hit the superior trunk. So you'll see the stoplight sign, you'll come down, and then you'll see these beef, chunky honeycomb regions in between the scalenes. Same thing, linear transducer. You're gonna do always with every nerve block, lateral to medial approach, always in plane. And then same thing, 10 cc's of analgesia, and you'll use your MD Calc or regional anesthesia app to calculate the max dose. So the target here, instead of, this probably is a better picture. So here's your interscalene, right, the 3 stoplight sign. And then as you scan down the neck closer towards the clavicle, you'll start to get these beefier structures. See, it's less well delineated than this one. And this is the superior trunk block. It will look more like the classic honeycombing that we're taught to find for nerve blocks. Again, just another picture. You can see the superior trunk and then the inferior medial trunk. You're going for the superior trunk. Just to bring it home, this is Jamie's anterior scalene. You scan down and then beefy structures, superior trunk. What I like to do, instead of just randomly placing my probe and hoping that I find these anatomical locations, you can always, and this is what Kazi does too across the street, you can always just start at the clavicle. You'll see your subclavian artery, really nice landmark, and then you just start fanning up. And as you fan up, you'll hit the superior trunk, fan up some more, and then you'll hit your 3 stoplight sign. And that way it's just an easy progression to find what you need to find instead of just slapping and kind of hoping you find it. So the reason superior trunk block exists is that there is this theoretical idea that has less phrenic involvement. Hasn't really panned out in studies, but people still do it because they think that it has less involvement of diaphragm paralysis. These two studies were just showing that one was the prospective single center cohort study that looked at blocks versus procedural sedation and saw that 93% of blocks led to successful analgesia, not requiring any other medications or like general anesthesia. And then the second study is a meta-analysis looking at length of time in the ED, and it showed that there was 77 minutes less time that patients spent in the ED when they did the peripheral block versus procedural sedation. So this decreases patient time, gets them out of your ED, decompresses CCT. Yeah, that's it.